Welcome to the Pro Ticker Deep Dive. Today we are diving deep into what is, arguably the most revolutionary shift in modern medicine. The metabolic megacycle, and specifically the seismic impact of GLP-1 drugs. You've seen the headlines. These pharmaceuticals are changing lives all over the globe. But if you look beyond the medical success stories, the financial forecast is just breathtaking.
It really is.
The global obesity medication market is projected to grow to nearly $880 billion by 2035.
$880 billion.
Right. That isn't just growth. That's a 13-fold explosion from today's market value.
And that number, it requires some context. I think the biggest mistake you can make right now is focusing on the old news, the drug approvals.
Okay.
That era is over. The focus has completely shifted into what we're calling the execution phase. The question isn't whether the science works anymore. The question is who can operationally deliver this therapy to hundreds of millions of people.
And get them to stay on it.
And ensure those people stay on it long term.
Exactly. So, if the drug works and the market potential is almost $1 trillion, what are the actual hurdles? What's stopping this money from just materializing?
Well, it really hinges on 4 critical operational bottlenecks that we need to break down today. First, manufacturing capacity can even meet this unprecedented demand.
Right, the shortages.
Second, insurance reimbursement. Who holds the keys to the kingdom by paying the enormous tab? Third is patient adherence, which is really the silent killer of real-world outcomes.
Okay.
And finally, the evolving battle between the convenience of, an oral pill versus the efficacy of injectables. If you understand these 4 dynamics, you understand where all the competitive leverage is.
Let's start with the macro picture then. Before we get into the bottlenecks, we need to understand the sheer scale of the crisis that's driving this whole market. This isn't a future threat. It's an urgent global reality right now.
Precisely. This market isn't being built on, optimism. It's being built on demographics. The global adult obese population is projected to nearly double within just 2 decades.
What are the numbers on that?
We're looking at a surge from 524 million in 2010 to a staggering 1.13 billion by 2030. That massive and frankly rapidly expanding population ensures the addressable market for these drugs isn't some theoretical construct. It's here now.
And that reality is what finally changed the perspective of the major payers, right? Moving obesity treatment from a sort of secondary wellness option to essential healthcare infrastructure.
That is the pivotal shift. Historically, insurers treated obesity as a lifestyle condition. Now, major payers, from Medicare and Medicaid all the way to self-insured corporations, they recognize it as the primary gateway to massive downstream costs.
So things like type 2 diabetes, heart disease.
Exactly. Heart disease, stroke, dozens of other metabolic disorders that cost healthcare systems trillions over a patient's lifetime. The thinking is, if you invest in resolving obesity today, you're essentially buying a deep discount on future chronic disease costs.
And that economic logic gives this market an undeniable tailwind. Analysts are projecting something like an 18% compound annual growth rate.
Right. And that growth is driven by 3 things. The rising prevalence of obesity, the proven efficacy of the new drugs, and this is the key 3rd element, expanding insurance coverage.
Which you just mentioned.
And we really can't overstate the importance of that 3rd element. Without coverage, these drugs remain accessible only to the wealthy. With it, the market opens up to hundreds of millions of people. The macro environment has laid the groundwork. Now we see who can build the roads.
That brings us to our first operational bottleneck, capacity. For, 2 years, the story was dominated by severe shortages. Patients couldn't get the drugs, which obviously limited the market. How quickly is the industry actually solving this?
They're solving it with just unprecedented amounts of capital. The capacity crisis of 2023 and 2024 is structurally resolving through these aggressive multi-billion-dollar build-outs. Novo Nordisk is investing heavily, but Eli Lilly's commitment is the real standout.
What are they doing?
They're undertaking a massive $27 billion U.S. manufacturing build-out.
$27 billion.
Across 4 new sites. This signals absolute confidence in the long-term demand and their intention to completely dominate supply.
Okay, so if that capacity comes online, and for $27 billion you'd assume it will be, the competitive landscape has to change. The consequence of easing a capacity crisis must be price compression, right? Supply goes up, pricing power goes down.
It has to. And we've already seen list prices fall dramatically by over 60% from peak levels in some channels.
Do we have specific examples?
We do. Novo Nordisk cut Wegovy and Ozempic list prices from around $1,000 down to $349 through their direct-to-consumer programs.
Wow.
And it's even as low as $50 for certain Medicare patients under the new generous model. The race is really shifting from who has the drug to who can manufacture it cheapest and fastest.
That sets the stage perfectly for Act 2. The formulations fight. We all know the patient preference is clear. A pill trumps a weekly injection every single time. Convenience is adherence.
It's the single biggest psychological barrier. Right now, we're contrasting semaglutide, which is available as an oral pill, with tirzepatide, Lilly's dual agonist, which is currently only an injectable. The issue is that the oral semaglutide, while convenient, can sometimes lag in efficacy.
And the real-world performance gap between the two is why this whole formulation fight is so high stakes.
Absolutely.
Yeah.
When we look at the real-world data, tirzepatide just shows superior performance. Users achieved a mean 5.3% weight loss over 6 months.
5.3%. And for semaglutide?
It was nearly double the 2.7% loss seen in semaglutide users in similar settings. Head-to-head clinical trials confirm this too, showing tirzepatide holding a consistent 4 to 6 percentage point advantage. That efficacy translates directly into a market edge right now.
And what's fascinating and important for you to remember is how the regulatory environment is kind of consolidating the market around these approved products. Earlier in 2025, the FDA restricted the compounding of tirzepatide.
That action in March 2025 was a huge event. Compounding pharmacies were a major gray market supply for patients looking for cheaper alternatives.
Right.
By restricting that, the FDA essentially forced a huge portion of the market back toward the two major pharmaceutical companies, solidifying their pricing power and control, at least for now.
Which puts the spotlight firmly on the future. The key indicator to watch now is Eli Lilly's development of an oral tirzepatide, which could hit the market in mid-2026. If they can solve that formulation challenge without losing that superior efficacy,
then that one product could completely redraw the competitive map.
So we have rising capacity, a clear efficacy winner in the injectable space. But none of that matters without mass access. Now we pivot to the biggest lever of all, insurance coverage. This is the true competitive mode.
It is. This is Act 3, the endgame. Historically, Medicare would only cover GLP-1s if you had a diabetes diagnosis, not for obesity itself. That monumental barrier finally crumbled with the announcement of the generous model in November 2025.
Let's pause on generous, because that sounds like policy jargon. What does it functionally mean for the market?
It's the policy mechanism that explicitly mandated extending Medicare and Medicaid coverage for GLP-1s when they're used specifically for treating obesity. It's a huge policy commitment that recognizes obesity as a treatable chronic disease.
And that unlocked a lot of new patients.
An estimated 7 to 15 million additional eligible patients almost overnight. It fundamentally altered the payer landscape.
And for Medicare Part D beneficiaries, this is rolling out in structured phases, I assume, to manage the initial cost shock.
Correct. The phases define the eligibility. Phase 1, starting in early 2026, will cover patients with a BMI over 27 who also have high-risk comorbidities like prediabetes or cardiovascular disease.
And then it expands.
Then Phase 3, expected later in 2026, opens coverage to anyone with a BMI over 35 alone, which massively expands the covered population.
So the public sector is moving and the private sector is following. We saw a survey showing that 67% of large employers now provide coverage,
which is a massive leap from just 19% earlier in 2025. This entire market is scaling up simultaneously.
But that speed, that must lead to an economic reality check for payers.
It does. They are struggling with explosive costs, and this is where you, as a skeptical analyst, need to focus. One analysis projected that Medicare coverage alone could cost the program $65.9 billion in drug spending over 10 years.
$56 billion.
And even after you factor in generous savings from reduced heart attacks and diabetes care, that's still a net increase of $47.7 billion.
Wait a minute. If we're projecting a net increase of almost $48 billion in cost, how can we call the tailwind undeniable? Doesn't that risk massive pushback or employers panicking and pulling coverage?
That's the right question, and it's exactly why the entire investment thesis relies on sustained, superior outcomes. Payers are making a massive upfront bet. If they spend that $48 billion net and patients don't stay on the drug long enough to realize the savings, the whole financial case collapses. That cost data gives payers the ultimate leverage to demand results.
And that economic urgency brings us directly to the third bottleneck, maybe the most important one, the silent killer adherence. Clinical trials show amazing weight loss, but the real-world data is Much more troubling.
It's the dark underbelly of this megacycle. Real-world data shows that over 50% of patients discontinue GLP-1 therapy within 12 months.
50%.
Which means half the investment made by Medicare and employers is essentially wasted in terms of long-term health benefits and cost savings.
And the outcome differential just reveals how severe this problem is. The early quitters, patients who stop in under 6 months, they only lose about 3.6% weight.
Barely moving the needle on major health risks.
Right. But those who persist for a full year achieve 13.7 to 18% loss. That's the level needed to justify that $48 billion investment.
So why are people quitting? The primary barriers are pretty straightforward. The high cost until insurance fully kicks in, access issues, and the persistent gastrointestinal side effects, nausea, vomiting.
Sure.
But here is the critical and often overlooked detail. Approximately 80% of GLP-1 patients are prescribed or are self-administering doses below therapeutic levels, often trying to manage those side effects on their own.
That's a huge operational failure. It compromises efficacy across the entire population. You're essentially taking a less effective and therefore more expensive drug in the long run.
Exactly. And to connect this back to our formulations fight, tirzepatide users show measurably better real-world adherence. Nearly 78% of its users reach the highest therapeutic dose, compared to only about 53% of semaglutide users.
Which implies that the superior efficacy and maybe better side effect profile helps patients stick with the full program.
That's the implication.
So what does this all mean strategically? If adherence stays below 50%, the valuations of these big players are at risk because payers will eventually pull back. This makes mega opportunity number one the solution to adherence.
It is the infrastructure play. The true competitive advantage going forward will belong to companies that bundle the pharmacotherapy with integrated, high-touch care digital health platforms, mandatory nutrition counseling, continuous telemedicine support. These are the essential services that guarantee ROI for payers by moving that adherence rate from 50% up to 75% or higher. They become indispensable.
Okay, so we have this duopoly right now. Novo Nordisk has the brand, the first mover advantage. But Eli Lilly has this superior product with tirzepatide's better efficacy and adherence data. Let's look at the pipeline, though. The future disruption is already being built.
The future is in escalating the mechanism of action. So tirzepatide is a dual agonist. It hits 2 critical receptors. The next frontier is triple agonists.
Compounds that hit 3 receptors.
GLP-1, GIP, and the glucagon receptor simultaneously.
For our listener, why is hitting that third receptor, glucagon, so important?
Well, GLP-1 is mostly about satiety, slowing digestion. GIP improves insulin sensitivity and helps metabolize fat. But glucagon helps boost energy expenditure. It actually increases the body's metabolism and how many calories you burn.
So you're attacking the problem from 3 different angles.
A powerful synergistic effect. It drives even greater weight loss.
And the early data on Lilly's leading triple agonist, retatrutide, is already staggering.
It is. Retatrutide showed approximately 24% mean weight loss in early trials. That's a level we've never seen before in pharmacotherapy. If that translates into late-stage success, it could entirely disrupt the current duopoly within the next 18 to 24 months.
So given the scale, the excitement, the immense investment, what are the 3 key risks that could stop this entire mega thesis in its tracks?
You have to monitor 3 things. First, adherence collapse. If persistence rates stay below 50% at 1 year, payers will tighten coverage. It weakens the whole financial case.
Right, number 1.
Second, price compression. With billions going into manufacturing, prices are going to fall. If they fall too aggressively towards the estimated cost-based levels, which some analyses suggest could be as low as $1 to $72 a month, it'll crush the profit margins.
And the third risk is tied to the broader economy.
Right. If the global economy hits a serious recession, large employers will feel immense pressure to cut costs. Pulling back coverage for high-cost GLP-1s would be a primary target, and that would constrain the market significantly even with the government expansion.
So, to synthesize all this,
if we pull it all together, the shift from the speculative approval phase to the demanding execution phase is complete. Success now is purely about operational excellence. Solving manufacturing, navigating payer relationships, and crucially, building the infrastructure you need to solve that adherence challenge.
And here's a final provocative thought for you to consider. The next major catalyst won't be a new drug. It will be the FDA approval of an oral tirzepatide. If Eli Lilly's pill can maintain that drug's superior efficacy while offering the ultimate convenience of a daily pill, well, it solves the problem of needle aversion and could expand the addressable market by 20% or more. This makes Lilly's execution on that oral formulation rollout in mid-2026 the single biggest, most actionable factor to watch in this entire megacycle. See you all in the next Pro Ticker Deep Dive.